So when we were faced with the virus as it started to spread, we were faced with a lot new problems. We can call these pandemic problems. So as we know, there was decreased PPE or personal protective equipment, which decreased access to care. Staff members with COVID led to quarantines and closings. Increased COVID volumes caused some healthcare workers to be redeployed to other specialties. Like in New York, earlier on, there were some providers that were prompted to leave their practices and go and take care of patients, or pediatricians who were assigned to practice in adult units or on the inpatient wards. There were issues where certain providers had to go home because they needed to quarantine, or they were actually sick with COVID, or some people actually passed away. As we know, those numbers, a lot of them include healthcare workers. And then there were other personal issues like the lack of childcare due to school closings and daycare outbreaks during the pandemic. A multi-site Mayo Clinic study, which sees 1.2 million patients annually, making it the largest U.S. healthcare system, reported a 78% drop in in-person visits from mid-March to April. That's 78% of people were not going to see their providers in person. And the U.S. in total saw a 42% drop in emergency department visits in April compared to the April before. So people were delaying care amid these fears of contracting the virus. And there were other reasons, as we stated before, where there may not have been as much access if your provider was redeployed or had to decrease their hours for lack of volume, or they needed to quarantine or decrease their cases. So telemedicine became a viable solution. It had a mission, allowing healthcare workers to triage by seeing which cases needed to present for an in-person exam or assessment versus safely be managed at home. This allowed in-person visits to be intercepted to avoid the spread of the virus by in-person care, and it also increased access to care. Not only were medical facilities overflowed with COVID cases, America had an access problem to begin with. The U.S. has a growing physician shortage, which is amplified in rural areas, in which only 9% of physicians in the U.S. serve 20% of the nation's population. People in rural areas are more likely to die from leading causes of death due to these growing barriers and the minimal monitoring of chronic illnesses, which is worsened by the void of care and a higher concentration of the elderly in rural areas. Telehealth has proven instrumental in expanding rural Americans' access to care, while also limiting financial risks to hospitals, allowing for the delivery of timely care, and limiting the costly transfers to rural hospitals, many of which do not have 24-hour physician care. So these are some scenarios in which telemedicine has been used during the COVID-19 pandemic. Telemedicine is being used in many scenarios, such as a patient with a mild respiratory illness with symptoms who needs an evaluation but who has been told not to go to the emergency room. A patient who has no symptoms of COVID but has become infected with the novel virus and wants to be evaluated because they didn't become infected, but they had contact with someone who was infected. And they need a note to isolate or next steps or testing. A patient who needed care for an unrelated reason, such as the management of a chronic condition like hypertension or asthma or diabetes, but they can't go in person due to clinic closure or their own personal fear of contracting the virus. A provider who's been quarantined during COVID but is not actually sick, they were exposed, so they can continue to see patients from their home via virtual visits. Or a patient with severe symptoms of COVID who's hospitalized and needs a specialty consult where there may not be that subspecialist in the house at that point, so they can do it virtually. Telemedicine's impact on the healthcare system has been to decrease the time required to get a diagnosis and initiate treatment, stabilize or quarantine a patient, facilitate close follow-up, minimize the risk of intra-hospital infection, support coordinated medical resources utilized in distant locations, and prevent the risk of contagion, particularly for healthcare workers. And as we know, COVID-19 has been a great imitator of the year. Similarly to the early AIDS epidemic, where almost any symptom could be HIV or AIDS, fever or no fever, loss of smell, diarrhea, telemedicine has provided ways to triage with a healthcare professional without going in person to expose healthcare workers, as well as allowing the patient to quarantine. Symptom checkers have popped up, as well as more refined triage mechanisms utilizing artificial intelligence. Here, we can look at a study performed by the University of California, San Francisco, UCSF, which created a patient portal based on COVID-19 self-triage and self-scheduling tool and made it available for primary care patients. Asymptomatic patients were asked about exposure, and they were provided relevant educational information. So symptomatic patients were triaged into one of four categories: emergent, urgent, non-urgent, or self-care. And then they were connected with the appropriate level of care via direct scheduling or a telephone hotline. So as we can see here, there were about 1,300 patients who accessed the tool. Almost 200 of them abandoned it, and of the about 1,100 who completed it, 315 or 28% were asymptomatic. So you want to ask, were they exposed? If they were exposed, you would recommend that they get testing or quarantine or do the appropriate care. If they weren't exposed, you give them appropriate education on COVID. If they were symptomatic, which was 72% or 814 patients, they were triaged according to their symptoms. Did they need to go to the emergency room? Were they having the chest tightness? Was their O2 levels too low? Did they need to go to the urgent care? Was it non-urgent and you can give them some things to do or follow up with them in a few weeks? Or could they take care of themselves at home and you give them supportive care tips? In the first 2 weeks of deployment of the tool, it was completed, like we said, over 1,000 times. And nearly 1 in 60 eligible patients completed it at least once. The tool was used primarily by symptomatic patients, but also included those 300 that we talked about. The tool was designed to do no harm and have a higher sensitivity to detect emergency level illness and a higher specificity when recommending self-care, both of which were greater than 85%. The tool recommended emergency level care with a higher sensitivity and decreased triage time patients for people with less severe illness. The data suggests it also prevented unnecessary triage messages, phone calls, and in-person visits. So this is also not only helping the one-on-one healthcare providers, but also helping the support staff decrease messages and phone calls and back and forth portal messages. Despite designing the tool with the conservative approach, the most frequent triage disposition was self-care. This tool may have therefore prevented hundreds of unnecessary encounters. Eliminating unnecessary in-person visits has the potential to prevent patient exposure to pathogens en route to the clinic and in waiting rooms, reduce the use of the PPE that we are finding so dear and sometimes hard to find by the clinical staff, and liberate frontline workers to focus on caring for sicker patients. One particular important benefit of this tool of self-scheduling, which allowed patients to be triaged and scheduled in a median of 2 minutes. Very few patients are triaged in 2 minutes in in-person care, so this is actually revolutionary.